Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent from developing and improve from suffering with brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a physician and Chief Scientific Wellness Officer at Kemper Cognitive Wellness, and I'll be your guide on these sound waves. So whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have a loved one with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's, dementia, and just generally things in life's second half. If you have questions or comments, check us out on social media. To support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show if you find these episodes valuable. That's Patreon, Patreon, patreon.com/evolvingpast. So here we go. Let's get better. Welcome back. I'm very excited about our guest today. Our guest is Anita Saltmarche. She is the principal at Saltmarche Health and Associates. Anita spent many years in academic and clinical medicine. She has been a primary and co-investigator on numerous clinical research trials and has over 17 years of photobiomodulation therapy experience, providing clinical educational research and consulting services. Her passion is treating those who experience neurologic conditions to assist them on their healing journey. Welcome to the show, Anita.
Oh, thank you. It's nice to be here.
Yes, I'm very excited. We're recording this in coronavirus craze. And so I mentioned the word photobiomodulation or transcranial-photobiomodulation, and you're a standout in this field. But I think we'll have to get into the definitions eventually, probably early on. But I'm just curious about your path, both in introducing photobiomodulation and how you in particular got into this field.
Well, actually, interestingly enough, it was one of those happy accidents, I suppose. I was doing consulting for a company called MedX Health, and they had a service of community health nurses, and they also manufactured laser and light therapy devices. And while I was there, they were asking me to review their literature and information on the technology. And when I read the marketing material, I sort of thought, no, this is not possible that light therapy can actually do all these things. And it was pretty early on in the process back in 2000. So I told them, no, I wasn't really interested in becoming involved. But as life would have it, I fell down a flight of stairs and hurt my knee. And the principal said, well, why don't you take this home and use it? And I thought, okay, I have nothing to lose. It's safe. And I was amazed at the pain relief, the decrease in inflammation and swelling in the area, and how quickly the tissue in the area healed. So I thought, wow, there actually is something about this. And when I started to do some research, which was predominantly being done at that point in time in Europe and Asia and Australia, because we didn't have approved technology here in North America, the research was really quite fascinating. I mean, the technology's been around for 50 years. And really the first research was around wound healing. So once I became more involved with that and felt this was something that could really offer patients and individuals a huge benefit, and the fact that it was, first of all, safe, had known side effects, and could be used in a number of different settings from medicine, chiropractic, physical therapy, nursing, it really interested me. So I joined MedX as their VP of Clinical and Scientific Affairs and started a 9-year journey with them. And it was an incredibly exciting time. New technology, new research. I mean, there were lots of uphill battles, but in trying to prove to clinicians that this actually had some merit. But I think we've really made some incredible headway over the past 15, 20 years in the area. So it was just one of those, I don't know if the accident was happy, but certainly the consequences were. So that's how I got involved.
Very interesting. So yeah, just serendipity. Can you kind of give us a brief overview of what photobiomodulation or light-based therapy is, just sort of to open things up?
Sure. Photobiomodulation is a more recent term, and the scientific community sort of met at the North American Association of Laser Therapy meeting and World Association when they had a combined meeting. I think it was in 2017. And we were really looking at using a term that more accurately really told the story of what light therapy does. And so if you look at photobiomodulation, which is not an easy term for a lot of people, it's really the use of light energy to bring about effects at a biological or cellular level. And interestingly enough, we used to think it was just stimulating, but in fact, depending on how the light energy is used, we can either stimulate cellular activity or inhibit that activity. So that's why modulation instead of photobiostimulation, which was used previously. If you actually look at the literature or talk to clinicians, there are many different terms that we've used over the years. And probably some of those that are more familiar are low level, either laser or light therapy, low energy therapy. There are a number of different terms that are still used in the literature, but I think photobiomodulation is a more accurate term about what's happening. Sometimes we just, the acronym of PBM is used as an easier, but maybe for today, light therapy is just an easier way for our audience to think about the light energy being used to bring about positive physiological effects. And when you think about it, we've actually been using light therapy for a long time, and people are familiar with seasonal affective disorders and using light boxes and the effect that can have. Or for young infants who have an increase in bilirubin and we used to put the kids out in the light. We now use light boxes to treat that. So there are many different applications. And as we hear about lasers and light therapy, certainly we're seeing that in the realm of aesthetics as well as in medicine or health related.
Absolutely. So kind of moving forward with that, like where these apply. So we're talking about light. So it's literally lights, right? It's literally LED lights.
Exactly. And again, about 15 years, 20 years ago, we used to believe that if we weren't using a low level laser, which is a collimated beam, the characteristics are slightly different. That was the only way we could see beneficial effects. But we now realize with the technology that has evolved that LEDs, light emitting diodes, usually of a medical grade, so we want that wavelength to be tighter. So when we talk about it being either visible or infrared at a specific wavelength, like 633, which is red, that we have the majority of that light. So those are medical grade LEDs. And we now realize that we can use both technologies. I think that's a good area to sort of introduce the idea. I mean, some people hear lasers, and when you think about lasers in medical practice, they're often used high powered lasers, and they talk about laser surgery. And so they're using a high powered laser to either cut or obliterate tissue, and this is not what we're talking about. Although we can use high powered lasers, they're tuned down, or the amount of energy being delivered is not so high as to create the heat, very high temperatures that allow them to do surgical procedures. Instead, we're using low level amounts of energy, a sufficient amount to deliver the energy we need to a target tissue to bring about that biological effect, but not to create heat. So it's non-thermal use. And quite often in photobiomodulation, it's the use of visible red and infrared light energy that's being used. But it is not technology or approach where it's the heat causing the effect. It is actually the photon energy.
Okay. And how do we know that it was the infrared or near infrared lights, or numerous kinds of lights or energy across spectrum tested? And because you mentioned 610, other people talk about 800 or 630, 810, and there's people that are just above 1,000, these devices. And
Right.
can you kind of get into that a little bit? Like, what are we talking about there? What are the terms that are being used?
Sure. So there are a number of different terms that we're going to hear. So when we talk about nanometers, we're talking about where on the spectrum that light energy is. So yes, there are other wavelengths. So we know blue, for instance, in that 400 range can be quite effective in killing bacteria, and it's often used for treatment of acne. So P. acne bacteria can be killed off with that. Probably 20 or 30 years ago, we used to use wavelengths that were lower than that, but also caused cell damage. And so
Mhm.
we tended not to do that. So we know that blue and yellow and many other wavelengths of light can be helpful. But when we talk about photobiomodulation, most often we're talking about that window, therapeutic window being between 600 nanometers. So that 600 to 700 nanometers is visible red. And that will bring about slightly different effects within the cell. And then when we talk about infrared, in that range, it's usually anywhere from the 700 nanometers up to 1,000, 1,200 nanometers. When we get into the 1,000s, we're often talking about high powered lasers at that point in time, but that infrared between that 700 and let's say 1,000 is a longer wavelength and will penetrate more deeply, whereas your visible red wavelength is a shorter wavelength and will have more superficial depth of penetration, but can have more of a systemic effect because it can be absorbed by the platelets in the blood and taken systemically or throughout the body. So wavelength is your nanometers, and it's either most often in this area visible red or infrared. And then one of the things that we can talk about, because it's another parameter we need to look at, is really the power and watts or milliwatts of energy. And most often, when we're talking about low level laser or energy being delivered, we're talking about milliwatts of energy. So that's the difference between our surgical lasers, where we're often talking multiple watts of energy. Most often, we're talking milliwatts of energy. So that's our power, and that's the amount of light energy that's emitted per second. And then often when we're talking about the power density or the intensity of that light, we're talking about watts per centimeter squared. And that's just a way of talking about what intensity of light we're using. Because if we want to be able to replicate clinically or in a research arena what I'm doing versus what someone else is doing, we need to be fairly specific about the terminology we're using. So that's your irradiance or your power density. And then one of the other areas that we often talk about is coherence. So the difference between a laser and an LED. And so a laser is coherent light and an LED is non-coherent. And the laser can have deeper depth of penetration depending on direct application than an LED. But I would not say exclusively that is the case, because how we deliver that energy or our actual method of application can also influence that.
What do you mean by that? Like in terms of where you apply, like, can you get effects on the brain by putting something on the knee? Can you say more about coherence versus non-coherence and just go into that a little bit?
Okay, yeah, absolutely. So when we're talking about laser being coherent, and as I said, we often thought that the laser was better able to penetrate into the tissue so we could get to deeper target tissue. That coherence means that the light is in step. If we look at waves of light. So light can either be particle or light waves. Those waves are in sync, that they're coherent. Non-coherent light, which is produced by LEDs, are not in sync. And one of the reasons that's particularly important, or why we thought lasers would be better able to produce that energy and have more effect, is there's a speckling effect. So as those photons of energy go and penetrate into the tissue, those photons can also be bounced back off the surface of the cell, and you end up with laser speckling. And that laser speckling can only happen with a laser. LEDs can't form that speckling. And as that energy is penetrating into the tissue, those speckles are higher density of energy, and that can be laid down, what we thought, more deeply. But it's not just direct penetration, which I think is one of the questions you were asking. I mean, whether it's a laser or an LED, yes. I mean, we used to think if I was treating a shoulder, I treat directly over that shoulder and that's my target tissue. But in fact, now we really have more of a segmental approach to treatment, which means, yes, we're treating over that direct area. But prior to doing that, depending on what the problem is, we may actually start with stimulating lymphatic drainage. So taking away some of those metabolites from that inflammatory process and increasing lymphatic drainage to an area. So if I had an inversion injury of my ankle, a sprain or strain, then I have some swelling and I've got a lot of pain. If I go to that area and I treat that directly without removing some of that inflammatory process and swelling, I can actually increase that pain. So instead, I would go to the groin area and behind the knee and popliteal area, and I would actually open up that lymphatic drainage. Then I would treat locally and get rid of that and ensure that I'm not increasing the pain. So treatment technique is very important. And as we became better able to understand the need for that treatment technique, we also realized not only lasers can do this, but LEDs can do this as well and be as effective.
So that's so fascinating, the staging and the treating upstream, downstream.
Yes.
So taking that into the neurologic conditions, as I know that you're deep in this, and that's actually how I learned about your work. So Alzheimer's, traumatic brain injury, et cetera, which of course traumatic brain injury and concussions are going to be precursors or risks. Somebody has a concussion or more than one, of course they are at a higher risk for Alzheimer's and other neurodegenerative conditions. Most of our listeners are aware of that. But how have you taken that idea of staging, or what are you seeing in photobiomodulation as it relates to neurologic conditions called Alzheimer's? And I realize that's a big question, and we're going to have to double click into that a couple times. But broadly speaking, we're talking about knee injuries and ankle injuries, and now we're talking about the brain and neurologic conditions, particularly that are thought to be derived or where the primary insult or injury is in the brain itself.
Right. Well, interestingly enough, I became involved with this about 18 years ago, and I had been teaching in Boston a group of chiropractors, actually. And about 3 weeks later, I received a phone call from one of the chiropractors, and he had had such great success with one of his patients who was indirectly also related to him for treating her knee. And she had arthritis and this decreased the inflammation and the pain. And she was so excited. She and her husband were in, and he is an engineer, and she was a very bright lady as well. But she had also sustained a concussion at the time. And so the husband was proposing, well, this has had such a great effect on her knee. Maybe we should try treating your head, which at this point in time, we hadn't been doing a lot of transcranial direct brain treatment. And so we worked together and came up with a protocol. I had contacted a number of colleagues in Europe and Australia prior to coming up with the protocol. And we decided to start to treat her transcranially. Didn't know if it would really work. But the thing I was more wanting to check out with a number of colleagues was ensuring that the same safety profile would probably be similar to the brain as anywhere else on the body.
Mm-hmm.
And yes, we all agreed that it may not be effective, but it should be safe. So we started treating the brain, and I received a phone call the following day from her husband because I gave him my telephone number in case they had any questions. And he started off, "What have you done to my wife? What's going on?" And I'm going, "Oh my God, this is not a
What
good
did I
way to
do?
start." Yes, exactly. She has slept for the last 13 hours, and she hasn't slept more than 2 hours since her concussion. She woke up, went to her computer, and was able to sit on the computer and see the screen without developing a headache for more than 2 minutes. She was on for half hour, and she was incredibly impressed with that change. And that was with the first treatment. So she continued to improve. She actually didn't return to work. She decided she didn't want to teach, but she was helping other individuals with concussion. And so one of the first things we witnessed with this treatment, transcranial treatment for concussion and traumatic brain injury, was the enhancement of sleep, which for so many of these individuals is huge. They just don't sleep well. So we saw benefit there. And as her treatments continued, her behavior changed. She wasn't having the same number of outbursts, and she wasn't finding herself becoming angry and flying off the handle without being able to control it. She could focus. Her headaches started to decrease. I mean, what we were seeing was really pretty remarkable. We were all thrilled. And so from there, started to become involved with a couple of other patients as well. And that really grew. Started working with Dr. Margaret Nazer from Boston and a number of other researchers. And so that was really how we started with traumatic brain injury, and have had a number of years of research under our belt with that condition. And so started to look at Alzheimer's. Could we see the same effect with Alzheimer's? And maybe this is a good segue into two questions that come up all the time. One is, well, what is photobiomodulation actually doing?
Yeah.
And if we think of that light energy, and we'll talk about, yes, we've got evidence that it actually reaches those cells. So if we just go with the assumption or accepting the fact that those photons of energy can actually penetrate through the hair, scalp, skull, which is really bone is fairly translucent, past the dura and into the brain. And we'll talk about that evidence.
So there's layers of the nervous system, layers of the brain, and then into the
Yes,
fluids.
absolutely. Right into specific areas that we need and want to treat. But what's happening? So those photons of energy can actually be absorbed by chromophores, little elements in the cell that have the ability to absorb energy or light. And once that happens, it produces a biochemical downstream effect. And what we're actually seeing is a number of different changes. We're seeing an increase in microcirculation. We'll talk about how that occurs. So that's important because we can get nutrients and oxygen to specific areas. We have a decrease in inflammation in the area, also very important. We can accelerate tissue repair and healing. And there's also a protective mechanism that can also occur. So there are many different things going on. So we know probably one of the areas that's been researched the most when we talk about mechanism of action is that the mitochondria, so that's the engine of the cell, has the ability, and the mitochondria are very important in the overall neuronal function or brain function because they supply cellular energy. And that energy is ATP. And the ATP is like the gasoline for the cell. So we have that engine within the cell, and now we're providing additional energy. And what actually happens then is that in that process, there's an increase in cell metabolism. So the activity of the cell is increased. And we're also seeing a slight increase in ROS, reactive oxygen species formation. And sometimes we think of that as not being a positive thing, but it's very short lived and helps to actually increase the ongoing production of energy within the cell. And so that can be very important. That increased level in ATP or energy in the cell also increases the nitric oxide dissociation from the mitochondria. And why is that important? Because that actually helps to vasodilate the vessels in the area.
Open up the blood vessels a little bit.
Yes, open up the blood vessels a bit. And we're not only seeing an increase in the dilation of blood flow, but also a dilation in the lymphatic flow, which is extremely important because we want to get rid of the toxins in the brain. So that can be quite helpful. And I'm sure many of your followers know with Alzheimer's that an increase in beta amyloid and tau proteins in the brain are felt to contribute to the development of the damage and the symptoms that we see associated with Alzheimer's.
Yeah, I mean, we've had guests, most recently Richard Isaacson, that even was talking about mitochondrial activity and glucose metabolism being primary drivers and maybe the harbingers, meaning the first thing, even possibly before amyloid and tau develop, that those are the first signs of dysfunction. And that's one of the things that's interesting to me about this modality of photobiomodulation is that it seems that, I know that Michael Hamblin's paper from, what was it, last year, 2019, I think, he proposes 9 mechanisms, but the mechanisms that seem to have the most evidence for them currently are those, or the mitochondria, metabolism, oxidative stress, reducing inflammation, all of which are really well characterized in Alzheimer's. And I can share a couple of examples, but can you share examples where people have improved just sort of clinically? We'll talk about research domain in a few minutes, but can you just share a story or two where people seem to improve, where they had real cognitive impairment,
Yes, and we'll talk a minute about the feasibility study we conducted and published in 17. But yes, there are a number of individuals in that study that really come to mind as being significant.
Can you explain, just give the background on the feasibility study and kind of who sponsored it and that?
Oh, yes. This particular study was sponsored by VieLight, and they manufacture a transcranial, so on the head device that has a head frame, as well as an intranasal device. And many go, what? You're putting a diode up my nose? And we'll talk about why that is the case in a few minutes. But yes, so they manufacture a number of different devices, but the transcranial one was the device we were using for this study. And feasibility we were hoping for clinical outcomes, but we were really testing the actual approach to our research. Could these individuals be brought in? So these individuals all lived at home with family caregivers, all of them essentially their spouses, and they were not in a nursing home or other facility. They were living at home. And what we were trying to do is see, could these individuals do part of this treatment at home as well as come into the clinic? So in the feasibility study, we were really starting to look at mild to moderate cognitive impairment, so fairly early on.
So I want to clarify this because this is one of my pet peeves. When people talk about mild and moderate cognitive impairment, if we're talking about Alzheimer's, right?
Yes.
You and I should have a back and forth because I've read this paper. I was very excited when I read it, and I remain excited about it. So mild and moderate, once people are testing abnormal, they have a profound amount of brain damage. So we call it mild because they haven't lost relative amount of ability to live independently. But if you're in the mild stage, if it's a dementia, if it's a mild Alzheimer's, by definition, you have already lost some of your ability to live independently. Moderate suggests even more loss of function, like forget about driving and taking medications and losing a phone. Classically, technically, again, there's a few different academic definitions, but technically, moderate stage Alzheimer's is where people have already lost the ability to do any of those, and they may or may not retain the ability to even get dressed by themselves. So these are profoundly sick people. I mean, so can you just kind of talk about the population of people I guess, in real life terms
Yes.
that you were studying?
And that's an excellent point. There are different definitions out there. For our study, we were looking, and it's a pretty, I suppose, relatively crude screening tool, but we were looking at the MiniMental state exam as a way of determining whether or not we would include these individuals. And so based on that initially, and that is normally scored out of 30. So we were initially looking at anyone who would score between 28, which is very good,
Yeah.
to about, I think the cutoff was 25 or 24. I'm sorry, I should know that. Anyhow, so it wasn't really significant. Now, it's not significant on a MiniMental state exam. Those are questions being asked of them. But when you actually looked, as you mentioned, in their day-to-day life, how did that impact their memory, their ability to function? Many of these individuals, there was no doubt about it, could not have lived individual or independently without their caregiver, their spouse. And I received a couple of phone calls as well. So that was that group. And I think we had, at that point in time, we published on 5 individuals, but there were 20 in total that were part of the feasibility study that we included later on. And as I received phone calls, we were turning a number of people away who, when I spoke to the caregiver, were fairly severe, and decided my clinical practice is, if these individuals are being cared for at home by a caregiver, we needed to see whether or not we could impact that. And so we brought in 3 or 4 individuals who scored 7, 9, 11 out of 30.
So these are profoundly, profoundly impaired
Yes.
individuals. Because I think the study was I was looking it up, is between 10 and 24 on that
Okay,
MiniMental
10 and 24. Okay, thank you.
Those are, again, very profound. I mean, those are.
Yeah, that is. Yes. But originally we weren't going as low as 10, and we had a couple, one at 9 and one at 7 later on. And I had one individual who was literally walked in by a son and daughter and could barely walk, hunched over and sat down, would make no eye contact, and looked to be quite depressed and had very difficult time. Although he did speak English, it was his second language. His mother tongue was Italian. And so I had to have the questions translated by the family, and I was really concerned. I didn't believe really at the time that the light therapy was going to have any impact.
Nor would I. I would be really surprised.
Yeah, I mean, having worked in this area for quite a while, just didn't think that this could possibly make a difference. And just to give you an idea of his functional level, so his mobility was not terrific. He required assistance by at least 1, if not 2. And he had a shuffling gait. He was not dressing himself. He had a caregiver. His wife had recently died over 6 months prior to this. He was sometimes feeding himself, but most often not. And he was not engaging in any real communication, meaningful communication with the family. He didn't acknowledge or would not accept that his wife had actually died, and wouldn't talk about it when the family tried to bring it up.
Yeah.
So he was profoundly impacted by his Alzheimer's. And he started to be treated in the clinic, and he was using an intranasal device at home daily.
Just the nose piece?
Yeah, just the 810 nose piece. So
Okay.
at that point, that's what we were sending them home with rather than the whole head piece, because we just didn't think maybe they could handle it on their own. And we wanted to know that it was at least happening. So the first 2 weeks, he came in and he was treated twice a week. And then he was only treated weekly after that. After the first 2 weeks, so he had 4 transcranial treatments and daily intranasal treatments with the 810. And at the end of his 2 weeks, he walked in with barely any assistance in a much more upright posture and looked at me. And we had been talking about rabbits because I live on a property that was fairly large and he used to like to cook rabbit. And he came in, looked at me and said, "So, do you have my rabbit?"
Wow.
And I just about fell out of my chair. I couldn't believe it. A month and a half into his treatment, his caregiver, who had a monitor, like a kid's monitor, where she could watch what he was doing while she was cooking for safety reasons in his bedroom and in the family kind of living room area. And he had gotten up from the breakfast table, walked into the bedroom, picked out his clothes and dressed himself, which he had not done in over a year. And the family were amazed. I was amazed. And he did die about 6 months after his treatment, but his family was so thankful because he was able to communicate with them. He would sit down and maybe not remember everything for sure, but he acknowledged his wife was dead. He could grieve and grieve with the family. It was so incredibly heartwarming to see this change. And this was from light therapy. I mean, we were really quite excited. And the other case that is particularly profound is this individual was really becoming isolated. He was living with his daughter, not communicating. He often would have phone calls with another daughter who lived out of town and wasn't really communicating with her either. His memory was declining. And I saw him at home and we started his treatment. And he did not score well on his MiniMental state exam. And he had previously been an opera singer, but had given that up, wasn't interested in singing. And he also did a bit of acting, but it was predominantly his opera singing. And I went to see him. I saw him, actually his treatment, because it was in Toronto, was done at home. So about the 6th treatment, he greeted me at the door and started singing an aria, which I was just, his family were so excited. And he recuperated, or improved so significantly that he was the first individual that VieLight, we were using their device, they're in Toronto, and they were doing some research and he was willing and the family were willing to come in and have him tested because he had improved so significantly and did QEEG, so quantitative EEG, and were able to demonstrate pre and post. So they did a QEEG reading and testing, and then they put the light therapy on, and in real time and after were able to see the changes in his brainwave activity. And he was the only individual in our feasibility study who had this done. And actually, Dr. Norman Deutsch saw him with me as well and was really quite impressed from a neuroplasticity perspective, really at how much from a communication perspective, his memory, his ability to then sing again, were really very significant, the improvement. So again, now, will this happen for everyone? I still continue to work in my own clinical practice with individuals. No, we don't see these dramatic changes for everyone, but we've certainly seen them. And they can be quite dramatic. And I now truly believe, even in those who have fairly severe cognitive impairment, this can make a huge difference.
So that's our episode. I hope it was useful to you. Check out the show notes on iTunes or on our website where we've summarized the key points. If you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. If you have questions or comments, connect with us on social media. Finally, to support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show. That's Patreon, Patreon, patreon.com/evolvingpast. Thanks, and talk to you next time.